So first, I'm just going to make sure it's showing up okay. All right. First, I'm going to talk about the origins of interpersonal psychotherapy before I talk about the pediatric adaptations. So the origins hail back to 1969 at Yale. Dr. Gerald Klerman and Dr. Eugene Pickel were tasked with designing a study to test the efficacy of tricyclic medications alone and with psychotherapy as maintenance treatment. As we all know, many patients have recurrence of depression when stopping medications, in this case tricyclics, after the acute phase of treatment. It wasn't clear how long medication treatment should last and whether or not therapy helped with prevention of recurrence of symptoms. Dr. Klerman felt that, Dr. Klerman felt that a trial should approximate real-world practices where most individuals received therapy. So IPT was based on the principles of Sullivan, who emphasized the importance of the interpersonal context of psychiatric illness, Meyer, who emphasized the importance of the patient's relationship with the environment, and Bowlby, who emphasized the importance of attachments and the impact of stress on attachments if they are disrupted. So they called it supportive or high-contact therapy, and they looked at what are the main reasons people sought therapy at the time, and those became the 4 problem areas of focus for IPT. So they manualized it, and while this group of researchers were developing IPT, Aaron Beck and his colleagues were developing CBT. So results showed the benefit of high-contact therapy, and it was renamed Interpersonal Psychotherapy. And in 1984, the first manual was published once efficacy was established outside of the original research group. This is the most recent manual. So I'm going to do a little bit of data. Pim Coopers conducted a meta-analysis of IPT for depression of 38 randomized trials. It included adults and teens with depression. It was IPT compared to controls. And it showed a moderate to large effect size in the acute phase of treatment for depression. Combination treatment was more effective than medication alone to decrease likelihood of recurrence compared to medication. There was no difference in efficacy between CBT and IPT. Then Paula Ravitz conducted a scoping review of IPT, published in 2019. You can see the number of publications, over 1,000. You see the breakdown of the disorders: depression, eating disorders, anxiety, bipolar disorder. It spans the lifespan. And so she really goes through the evolution of IPT, again, beginning with the origins for acute and maintenance treatment for middle-aged and older depressed adults, and going through the studies that IPT and meds are most effective at preventing recurrence of depression, then the adaptation of IPT for bulimia, and for those with late-life depression and adolescents with depression. It was then expanded to the peripartum period, and then expanded to low and middle-income countries to be delivered by non-mental health workers, eventually called interpersonal counseling, which I will talk about a little bit later. So the basic concepts are, there's a relationship between the onset and/or maintenance of depression and interpersonal relationships. Social support safeguard against depression. Social stress is associated with depression. I always say, if you only want to remember one slide, this is it. There's a bidirectional interaction between mood and interpersonal relationships. The example I give is, if I'm a teen who's irritable, I'm more likely to get into arguments with my parents. It'll impact those relationships. If I get into arguments with my parents, it's likely to adversely affect my mood. Bidirectional. The goals are to decrease depressive symptoms and improve interpersonal relationships. I'm going to go through a couple of adult adaptations before I talk about the pediatric adaptations. So IPT for adults with bipolar disorder was developed by Ellen Frank. It's called Interpersonal and Social Rhythm Therapy. This is the manual. It's a longer duration of treatment, and in the randomized controlled trials for adults with bipolar spectrum disorder, IPSRT is adjunctive to treatment with medication. Those individuals had improved depressive, manic, and anxiety symptoms, faster recovery from depressive symptoms, increased time to recurrence of episodes, decreased duration and severity of mood episodes, improved psychosocial functioning, and improved response to medication. The next adaptation I'm going to talk about is IPT for PTSD, developed by John Markowitz at Columbia. So this is a non-exposure affect-focused treatment. The idea being that individuals with PTSD can have interpersonal challenges, such as social withdrawal, mistrust, and social supports can be beneficial. Focuses on interpersonal events. Also, since IPT has benefit for depression and PTSD is highly comorbid with depression, perhaps it would be, beneficial. So in the first large randomized controlled trial, they compared IPT for PTSD compared to prolonged exposure and relaxation therapy. At this time, exposure therapy was the gold standard. And they found that IPT was non-inferior to prolonged exposure. And this was pretty seminal work because it's expanding our evidence base of therapy for those with PTSD. Anyone who's worked with individuals with PTSD know that the sort of exposure to the trauma is particularly challenging. Some individuals prefer not to engage in that, and now we have another therapy to help them. It's always good to add therapies to our toolbox. And then John Markowitz also completed a review of 13 studies of individuals with PTSD, including civilians and military veterans, and found that IPT was non-inferior to prolonged exposure and medication. So one last, this sort of shows the global context, the global reach of IPT. So the origins of this sort of project are actually start in the early 2000s. Researchers from Hopkins and Columbia conducted a study, IPT group, in rural Uganda, delivered by community workers. They randomized the villages, and those who received the IPT group had significant reduction in depression. So Sean Mayberry created Strong Minds, which is an NGO, in 2014, and it's for individuals with depression in Uganda and Zambia. It's 8 weeks, an 8-week group, and as of 2023, they have treated 230,000 individuals. It's free, it's delivered in local languages by trained facilitators. And on average, 80% of individuals are depression-free at the end of therapy and 6 months later. Former clients are trained to lead future groups as peer facilitators. It's self-sustaining, it removes the stigma of mental health. IPTG has become a World Health Organization first-line intervention for depression. And if you see the burden scale, this is an adaptation that Sean Mayberry and his group included, and it really helps facilitators ask participants about mood and feeling without specifically saying, how is your depression? So how heavy is your burden today? Okay. Now I'm gonna talk about pediatric adaptations, the first of which was by Laura Muffson at Columbia. So in general, IPT is time-limited, manualized-based, 12 to 16 sessions, focuses on the here and now, and there's 3 phases of treatment. This is the manual. So the teen adaptation, it's shorter or briefer than the adult model. It includes a concept called the limited sick role. There's contact with schools and parents, and it focuses on developmental issues pertinent to teens. So in the studies of IPT versus treatment as usual, the IPT group had improvement in Hamilton Depression Rating Scales, better functioning on global assessment scales, and better social functioning. Other studies led by a different research group compared IPT and CBT with waitlist in Puerto Rican adolescents with depression, and they found that both CBT and IPT groups had a decrease in depressive symptoms. There's been demonstrated benefit in youth with diverse backgrounds. Just to go over a little bit about the model, the initial phase, we go over the diagnosis of depression. We assess for any comorbidities such as anxiety or ADHD. We provide psychoeducation. Likening depression to a medical model, we want to remove the stigma, remove blame. We liken it to having the flu or asthma, some sort of medical illness. We talk about a concept called the limited sick role. So if you're a teen and you're depressed, you have low energy, low motivation, it's hard to get out of bed, it's hard to go to school. We're going to decrease our expectations, and as you improve, we're going to increase our expectations. So maybe you just go to school, you just do your homework, no extracurricular activities. We really kind of want to cut you some slack while you improve. The parent sessions, we again provide psychoeducation. We talk about this concept, the limited sick role. We go over confidentiality and their role in treatment, which depends on what the focus is. We review depressive symptoms at each session. We want to track change over time. And we include something called mood ratings. What is your best mood of the week? What is your worst mood of the week? And what is your overall mood of the week? Claire's very familiar with that. Claire's rolling her eyes. We want to link those moods to interpersonal events, what's going on at that time, so we can figure out what makes your mood worse and better. And this is a skill that a lot of the therapists use independent of whether or not they're using IPT as the model, because it's a pretty good way to kind of figure out what's making mood better or worse. Again, something that Laura Muffson included, it's called the closeness circle. So it gives us a pictorial representation of the important people in one's life. So the teen is in the center circle, and then we ask them to tell us who the important and close people in their life are. The closest ones are in the circles closest to the center. The ones that they feel less close to are further out. And also this is a good skill that we use a lot of times in treatment, even if not with an IPT focus, because kids are very social and it's important to know who the important people in their life are. And we pay attention to who's there and who's not there. So did you list 30 friends and you can't tell us who you feel close to? Do you have no friends? Did you leave out step-parents, siblings? Really gives us a good idea of figuring out sort of their social relationships. Then after we do the circle, we do an inventory where we pick the 4 to 5 most important people in their life and do a deep dive. What are the positive aspects of the relationship, the negatives? What do you argue about? What do you like to do? Is there anything you want to change about this relationship? Once we finish the inventory, we come to a formulation collaboratively with the teen, and in that formulation, we together decide on a problem area of focus. So there are 4 problem areas. So grief is depression in the context of the loss of a loved one. Role transition is depression in the context of loss of a loved one. Transition is depression in the context of a life change, such as a move, change of school, or even the developmental stage of adolescence, and any family structure change, divorce, remarriage. Disputes is depression in the context of the conflict with a specific relationship, and then deficits is depression in the context of loneliness and isolation. The middle phase is where we do the work. Review of symptoms, we start out every session, mood ratings again, and then one of the skills we use is something called a communication analysis. We map out a conversation. What did you say? What did he say? What did you say? What did he say? So we know what the dialogue is. We pay attention to verbal and nonverbal. What tone of voice did you use? How did you stand? What was your posture? What was the message that you wanted to send? And is that the message you did send? Really helps with empathy and perspective taking, and we want to empower the teens to know that small changes can change the interaction. Decision analysis is an interpersonal situation causing a conflict. We have the teen come up with possible solutions, then we go through the pros and cons with them. We ask them to choose a solution, try it out, and then tell us how it went next session. We do a lot of role plays. As you can imagine, if you've done a communication analysis and you've seen an unsuccessful communication, we would want to then try to craft a more positive, hopefully successful communication. So we have the teen and therapist play both roles. We want the teen, it helps with perspective taking, to take the role of your parent. It also kind of helps you see how a conversation might go south pretty quickly. We also have them role play the worst case scenario because we want the teen to be prepared. This helps with improving confidence and practicing skills. We don't call it homework, we call it experiments. It's work at home. We don't know how it's going to go. It's to help with skill building, and we want to then have them report back how it went. Parental role really depends on what the focus of treatment is. So direct work, if there's a conflict with the parent and the teen is having trouble communicating outside of session, we'll invite the parent in to help kind of discuss the skills and role model the effective communication. If disputes isn't an issue, we might just have a parent or guardian, I've had grandparents, whomever, come in and just give updates on how they can support their teen. So again, Lara Moussine with colleagues developed the teen tips. So aim for good timing, strike while the iron is cold, even if you have to suck it in a little when the iron is hot. This really is about perspective taking. When is a good time to have an important conversation? Not after your parent has a 12-hour shift at the ICU. Let's think about if your parent is tired, hungry, what mood they're in. Let's schedule an important conversation. Can we talk on Saturday at 2 o'clock, whatever. I also talk to teens and parents. I've read a lot of pop psychology about the car is the best place to have important conversations with your teens. It is not the best place because you're the parent and you're driving and you can't focus on your kid. And if you're going to get into an argument, no one can escape. So I don't recommend the car. I've had plenty of people who get heated in cars and there's no escape. So thinking about what is the best place. So give to get. Start with a positive statement to show how you know how they feel, and then say what your ask is. Again, perspective taking. I feel statements, say how you feel about the situation. People are not mind readers. Have a few solutions in mind. Hey, Mom, I want to go to this party. Can I call you every 2 hours? Can you call the parents? Whatever it is it better to have a couple solutions to propose to get part of what you want versus nothing? Compromise, right? Don't give up. There are long-standing patterns of interactions. It takes time to change. So termination is the end, the sadness of not coming into therapy versus the sadness of recurrence. How did your symptoms progress over time? What were they like at the beginning? What are they now? What are your warning signs of recurrence? What teen tips worked? How in the future, if you might have a stressful interpersonal interaction, can you use those skills? Okay. So the next pediatric adaptation I'm going to talk about is by Jamie Young, who is currently at CHOP. It's a prevention model. It's Interpersonal Psychotherapy Adolescent Skills Training. It's a group-based model, and it's for the prevention of adolescent depression. So if youth has subthreshold depression, they're at increased likelihood of developing a future depressive episode. It's primarily delivered in schools. There's a pre-group session, 8 group sessions, and an individual or dyadic mid-group session. In the first study of middle school and high school students with elevated depressive symptoms, they were randomized to IPT-AST or usual school counseling delivered by a school counselor. So the IPT group had significantly fewer depressive symptoms, improved global functioning at end of intervention, 3 and 6 month follow-up. At 1 year, approximately 4% of the IPT youth reported a depression diagnosis compared to almost a third of adolescents in the school counseling group. The IPT group also had decreased parental conflict. In the second study of high school students, again with elevated symptoms of depression, the IPT group had fewer depression symptoms, better overall functioning at end of study in 6 months, but the differences didn't last over time. There's also some data to show that the IPT group had significant reduction in anxiety compared to the school counseling group. Thus far, it's been delivered in diverse settings, urban and rural, to teens from diverse ethnic and racial backgrounds and varying socioeconomic backgrounds. More recent work has focused on personalizing depression treatment, so looking at what factors will increase the likelihood of response to either IPT or CBT. They did a few studies looking at those factors. There's also work in primary care for depression, so a colleague, Molly Davis at CHOP, is developing a briefer version to be delivered by embedded therapists in primary care settings. So the next adaptation is for pre-adolescent depression, developed by Laura Dietz at Pittsburgh. It's called family-based interpersonal psychotherapy. The rationale being that pre-adolescent depression is underdiagnosed and undertreated. There are increasing rates of suicide. Laura includes more parental involvement at each session. The goal is to decrease parental conflict and improve peer relationships. She includes the parent tips and tween tips. An example of a parent tip is self-care, put on your oxygen mask first. Consider the intention and not the outcome. And there's also a focus on comorbid anxiety. As we all know, anxiety can impact peer relationships. We heard Claire tell us about that. And also includes visual materials to help concretize the skills. So in a randomized control trial comparing IPT family-based with child-centered therapy, which is a supportive non-directive therapy, the IPT group had a higher remission rate, 66% compared to 30%, a decrease in depressive symptoms, significant reduction in anxiety, and the IPT group had greater changes in peer and social impairment. The next adaptation is by Stephanie Halastala, based on the adult work by Ellen Frank. So this is adapting the interpersonal and social rhythm therapy model for adults for adolescents with bipolar disorder. 18 sessions over 20 weeks. There's a psychoeducation component and includes this model of bipolar disorder where you can see stressors precipitate or exacerbate bipolar disorder episodes by disrupting social and sleep routines through disruption of the circadian rhythm system. She also adapted the social rhythm metric developed by Ellen Frank for adolescents, and I'll talk about that. There's obviously a focus on interpersonal relationships. There's also this concept called role transition, really talking about going from someone with a diagnosis of with someone who hasn't had the diagnosis of bipolar disorder to a new diagnosis of bipolar disorder. It's a transition. I have a lot of teens and young adults coming in with a new onset manic episode, no prior mental health history, and they're really having a lot of identity questions. Who am I? Is this my mania? Is this me? Can I still be the same person with this diagnosis? What does it mean to be taking these medicines for my mood? There's a lot of identity exploration, and I found this model is really helpful. So in an open trial, they found that IP-SRT for adolescents, there's high feasibility and acceptability and high satisfaction. They also found decreases in manic depression and general psychiatry symptoms, and global functioning improved. So on the right is the bipolar disorder, the timeline, where you track hypomanic, manic, and depressive episodes, looking at life events, sleep changes, social school functioning, and consistency with meds, really looking at what is precipitating episodes. Did you pull an all-nighter in college? Did that precipitate an hypomanic episode? Did you forget to take your medicine when you went on a trip with your roommates? Whatever it is, what are the triggers for episodes? And then the social rhythm metric, again, adapted for adolescents, looks at anchors to the day. What time did you get out of bed, your first social contact, your structured activities, what time did you eat dinner, and what time did you go to bed, and then linking the mood to that. And it looks at target times and actual times. The idea being that if you stabilize your sleep-wake cycle and your social rhythms, and honestly your biological rhythms, including your meals, it's going to help stabilize your mood. And so, you know, if you stay up late all weekend and then you have to get up early Monday for school or work, how is your mood? Do you see an impact on your mood? And then hopefully by looking at these, you can make changes over time to help stabilize the rhythms. The next adaptation is one that I developed during my K-23 Career Development Award, Interpersonal Psychotherapy for Mood and Behavior Dysregulation. I was very lucky to learn IPTA from Laura Muffson and IPSRTA from Stephanie Lastala, using these to create the adaptation for youth with DMDD. DMDD is characterized by chronic irritability and outbursts. Irritability leads to outbursts. Outbursts lead to problematic relationships since they're generally in an interpersonal context. So we have a longer duration of treatment due to the chronicity of the illness, and I modified the psychoeducation component, conceptualizing DMDD as an externalizing mood disorder. There's an affective and a behavioral component. Sometimes people forget about the affective component because all they see is the behavior. So really remembering there's two parts to this. A lot of these parents feel that they're walking on eggshells around their teens. So we talk about a concept called accommodations. Accommodations are what have been put in place either intentionally or unintentionally to reduce the outbursts over time. We acknowledge them, and over time, as symptoms improve, we want to decrease the level of accommodation. There's also more parental involvement. So really addressing safety issues initially, coaching the parents to disengage. The teens are very dysregulated initially. We want the parents to try to disengage from the conflict. We include outburst readings. What is your worst outburst of the week? And then we link it to whatever interpersonal event or trigger was going on at the time. We complete the circle and inventory, then really talking about how disengaging leads to de-escalation, and de-escalations lead to better mood regulation. So over time, the less outbursts that the teen has, the more regulated they are, and they can actually disengage from the conflict before it sort of becomes a 10 out of 10. We do a lot of communication analysis, dissecting the outburst, doing a lot of perspective taking. How did you feel? How do you think your parent felt? How do you think your friend felt? And then the parental involvement really depends on the age and skill level of the teen. So at the end, we assess need for continued treatment, comorbidities. A lot of these individuals have comorbidities, and then also assessing for any subthreshold symptoms that might still need to be treated, or if there's continuation of symptoms. We review the progress made. We generalize skills. Anyone who would like to read more about it, there's an evidence-based case study I wrote about the adaptation, and also completed a pilot study of IPT MBD versus treatment as usual, found that IPT was both feasible and acceptable based on satisfaction scores and attendance to sessions, and the clinical global impression scales for severity and improvement showed statistically greater improvement in the IPT group compared to treatment as usual. Anecdotally, I just bumped into the parents of one of the teens who was involved in the study, and the youth is now a young adult, and they told me that the young adult is thriving, so that was pretty awesome to hear. I'm next going to talk about some adaptations for college students. As we all know, college is a time of transition, moving away from home, managing increasing autonomy and independence, having to live with roommates. College counseling centers, they have increasing numbers of students, limited resources, and in general, those with mild to moderate depression have longer to wait because those with acute severe depression and suicidality have to be seen first. So interpersonal counseling is a briefer model, and it originally was developed in primary care populations. It's briefer, it's delivered in non-mental health settings such as primary care, and it's delivered often by non-mental health workers such as nurses. There's an evaluation support triage model. At the end of treatment, you decide, do you need no further treatment? Do you need monthly check-ins, or do you need to be referred for more intensive treatment? So my colleague, Alexandra Raffaelli, developed interpersonal counseling for college students for at university counseling centers. She initially developed it for international students while working at Tel Aviv University Counseling Center. I happened to meet her at a meeting, and we then talked about collaborating on expanding it to other college counseling centers. So we conducted a very small pilot study at Homewood and Amherst and found a statistically significant improvement in depression scores and college adjustment. We then collaborated with Colleen Conley at University of Loyola Chicago on a group model also delivered in college counseling centers. So they have an individual pre-session where they assess the suitability, develop the formulation, introduce the circle and inventory. They have 8 group sessions and then a debrief session. So they found that when they compared IPT-CS to treatment as usual, that those with IPT had reductions in depression and anxiety that were clinically significant, and they had statistically significant changes for depression and social support. The last adaptation I'm going to talk about is developed by Anat Bronstein-Klomek in Israel, and this is IPTA for suicide crisis intervention. Again, to address an unmet need, there are a lot of youth with suicidality presenting to the emergency room, lengthy waits for outpatient services. So it's a briefer model, 5 sessions. Safety planning, focusing on the interpersonal context of safety planning. A lot of psychoeducation about suicide risk factors, and then really focusing on emotion regulation and interpersonal skills. And then there's 4 follow-up communications to the parent and or teen, depending upon what's been decided. So I think Holly was here. So Holly is leading us in a PCORI multi-site funded study comparing safety planning intervention, which is enhanced safety planning with caring contact follow-ups, compared to the IPTA SCI. So as we all know, suicide is the second leading cause of death in this age, the youth and young adult population. There's increasing rates of suicide. So this study is youth 12 to 19 years old who present to an acute care setting with suicidality in the past 4 weeks. We're following these youth for 12 months with assessments at 3, 6, and 12 months. We are focusing on minoritized youth given the increasing rates of suicide among Black and Hispanic youth, and LGBTQ+ youth also have an increased risk of suicide. The primary outcomes are suicide ideation and attempt using the CSSRS. Secondary outcomes are quality of life and mental health service utilization. These are the sites: Hopkins with all children's, Columbia and Cornell, CHOP and UNC. SPI focuses on preventing crises. IPT focuses on safety planning as well, but also underlying risk factors such as interpersonal problems and emotion dysregulation. Anyone who is interested in learning more about IPT, there's free trainings. IPSRT.org has a free training for the adult model for bipolar disorder. Laura Muffson and Jamie Young have on YouTube, it's from the Effective Child Therapy website. They have IPTA trainings. Paula Ravitz developed a free IPT course on Coursera. And as I mentioned, the WHO Group Manual is publicly available. So we have the International Society for Interpersonal Psychotherapy. This is from their website. I just want to show the reach of all the trainings and research, the global presence of IPT. And they have special interest groups, of which I co-lead the pediatric special interest group with 2 of my colleagues. We lead case consultations and have experts talk about adaptations. Next month, we're actually going to have an individual talk about the adaptation for youth who have chronic medical illness, and this time it will be insulin-dependent diabetes. And then those are the other special interest groups. Just gives you an idea of the breadth of IPT. And that is it.
Thank you so much, Dr. Miller. Really interesting presentation and interesting work that you're doing. Let me start by asking this. I suppose CBT is probably the most widely known and I imagine widely used protocolized psychotherapeutic approach. Are there particular types of young people who you decide are more appropriate for CBT and others you decide are more appropriate for IPT, and how do you make that call?
No, it's a great question. It's actually something that's part of what Jamie Young is doing, looking at kind of, do you have more like cognitive distortions, like at baseline, do you have more interpersonal problem areas? And so at baseline, can we kind of do an assessment to figure out who might respond better? I think that most teens like talking about their relationships. They're very social at that age. And so I think IPT is a pretty good intervention. I think that we don't have as good marketing as CBT. We're sort of the underdog therapy. And so I think that it works really well. I think sometimes teens struggle with challenging their distortions. They kind of keep coming back and sort of that sort of model. So I think, they're both highly effective, but I think you do your assessment and figure out kind of what would be best for the teen in front of you.
Yeah, no, that's a very interesting point. Dr. Yue.
Oh, hey. Might you tell me a little bit more about what you're asking?
Well, like I'm wondering if, for example, IPTs on average more efficacious and emphasize relationships with more East Asian, maybe East African versus more ubiquitous American, Western European.
I'll just repeat the question for people who might be listening, right? Are there cultural factors that might influence the choice of CBT versus IPT?
I think that that's actually the cool thing about IPT is that everyone values relationships. And so there are, I mean, in the UK, the NHS actually provides free training for IPT because the data is as effective as CBT. So I think that you can do cultural adaptations, like that burden scale I think is sort of an interesting adaptation. We might do like a mood rating scale, but it's actually globally shown to be effective. I mean, we have chapters in Europe, Australia, New Zealand, Canada, the States. You saw, we have them in China, trying to think of all the places, but it's sort of globally because of the importance of interpersonal relationships. It can be, adapted as needed, but I think inherently we're all sort of like social beings, and so I think it works.
Thanks.
Pretty
Is
much
that Dr.
everywhere.
Platt back there?
Oh, sorry. Do you need to repeat it? Or?
Yeah.
Oh,
Have you
okay.
treated patients with comorbid ASD? Is that what you said? Autism spectrum disorder?
So it's interesting because originally it was thought that because it's a brief model that it wouldn't necessarily, work for individuals with ASD. I have to say anecdotally, I've had a lot of individuals who have pragmatic language disorders, which is sort of like not quite ASD, but sort of, adjacent perhaps. And so I think the perspective taking is super helpful for those individuals, and I've seen it to be effective. I think you just sometimes have to extend the duration of treatment, but there is actually work by a colleague, Roz Law, in the UK working on adapting it for individuals with autism. So that's sort of very new. So it'll be interesting to see what those adaptations are.
Interesting. Gabrielle?
Yeah, so at ISIPT we have a biannual conference, and so this past March in Newcastle, I co-led a seminar on cultural adaptations of IPTA, and a colleague from Hong Kong talked about, Janet Lam gave this amazing presentation on cultural adaptations. If we think about it, like in the US, we sort of really value independence and autonomy in adolescence, but in the culture, right, in Hong Kong there's more of a hierarchy, and so figuring out how to help the adolescents who maybe are struggling with some autonomy and independence, but to fit within that hierarchical model. There's also a lot of sort of emphasis on family cohesion as opposed to individuality. And so she gave this beautiful presentation talking about how they adapted the same model for use in youth in Hong Kong. So.
Interesting. Dr. Sharf?
Oh, hi.
Sorry, I'm not sure. I heard the limited what? What
Limited
word?
sick role.
Sick roll. Okay.
Do you need to repeat it or no?
How does essentially how does the sick role factor into the thinking here?
So we don't use that term with the teen and the parent because it's kind of maybe not the most positive term, but really talking about kind of meeting the teen where they're at.
Okay,
So
close to the microphone.
Sorry. So we see teens with different levels of depression, right? If you have a teen who's pretty severely depressed, just getting out of bed and going to school is a win, right? And so we're going to say, we just need you to get out of bed and we need you to go to school, and we're going to decrease the amount of homework you have or try to have no homework, right? Really looking at how severe those symptoms are. We have a teen with moderate depression, maybe we can do some homework, get out of bed, and maybe no extracurricular activities, really figuring out what they're able to do. So we want to cut them some slack. We want them to understand it's not them, it's their illness, right? Externalize it, remove blame. Sometimes parents have a harder time understanding the depression. We don't want them to see their teen as lazy, and so we really want to provide a lot of psychoeducation about that. And then over time, as they improve, we're going to increase our expectations. We're going to add more homework. We're going to bring back in the extracurricular activity that you weren't able to do. So it's really sort of a process over time.
Great. Thanks. Is that Dr. Schreier?
So I'm not as familiar with the adult model, but they do, they've used it for individuals with borderline personality disorder. They do a lot of mentalizing, which is kind of like perspective taking, but not. So Laura Muffson will always say, if you're a depressed teen, we can't figure out what is depression and what's your personality. Let's treat your depression first and then see what's left. And so that's kind of, I think, the approach I would take, but I think perspective taking is a super useful skill for almost really anyone, especially teenagers, and so we do a lot of kind of affective identification and perspective taking, and then the group model, I'm not as familiar, I haven't been trained in the group model, but I do think it could help because you talk about your experiences, you learn from their experiences, and so I think it can, again, help with sort of like this perspective taking.
Terrific. Other questions? Dr. Rubel. I'll just repeat the question. How do you think about the idea of keeping psychotherapy as a critical part of the mix in how you approach the patient?
I think from the beginning of my career, I've sort of valued it and seen the importance of it. As I mentioned in my K-23, I actually got to adapt therapy. I really value a combined treatment approach. We have team-based discussions at Bayview, so Stacy and I work very closely together in patient care. And I just sort of really, IPT resonated with me. I think it really can be used with almost anyone. And I actually embed, because I sort of know IPT and I know DBT and CBT, though not trained in them, I embed reinforcement of skills in all of my sessions. So the therapist and I talk about what model you're using. So I would say to Clara, like, what's your exposure? What is Stacy having you work on? Or what skills are you using? Because I think it's super important for us to reinforce. On the flip side, the therapist will say, hey, you having any side effects with your meds? Do you need me to like reach out? Like, are you remembering to take your meds? Can we problem solve? I think it's super important to have kind of this team-based approach. And so we sort of weave it into our treatment in general, I would say.
Maybe I'll ask a follow-up to that, which is, how critical do you think a model is as opposed to using a common factors kind of approach?
Yeah, no, it's an interesting question. I think there are sort of common factors that everyone should use in therapy, right? I think having a focus, even if it's for X amount of time and agreed upon focus and treatment, I think is just helpful, because you say, well, I'm going to use CBT for 8 weeks and we're just going to do exposures. Otherwise, I worry you're kind of not going to get enough momentum and really, kind of flip between different therapies. And I think it's important to have skills to hang your hat on personally. And so if you have a model, even briefly, or like we talked about, you weave between different therapies, but you kind of say, this is what we're going to focus on now, and then you move to the next one and say, we're going to just focus on this one. So I think it's fine to switch models, but I think you really have to have some sort of focus, or I think it might get a little lost on what you're doing.
Good point. Okay. Anybody else? If not, thank you for a very interesting round.